Okay, good morning and welcome to the Vascular Vein podcast. I'm Nicole Redman. I'm hosting it today from South Africa. And our topic today is the vein heart, the calf pump. And we have quite a wide panel on, and I asked everyone to come for different reasons because I think it's quite an important topic. And we've seen a problem with the use of the calf pump from foot issues or vein issues or anything more and more, and getting a better understanding of it. So I'm just going to introduce everyone on the panel. We've got Sergio Gianesini. He's a vascular surgeon all the way from Italy, and he's done extensive research and international work on everything venous. He's sort of one of the leading venous experts. And a lot of your research, Sergio, has been on venous physiology. So that's why I'm very pleased to have you on board for this. And Fred Louw is an orthopaedic surgeon at Christian Barnard with me here. And we've also been interacting more about patients when they've got ulcers that don't heal from lack of the calf pump. Sean Pincus, who's a podiatrist, and we've worked together for a long time, and he knows it's a big topic we've always discussed over and over. And then Nicole Redman, who's actually my sister, she's a physiotherapist, and we've had numerous discussions on this because it's also an interest to me. So I've asked her about neuromuscular stimulation and everything. Okay, so I think what we can do, please all just interrupt each other and chat with each other and, make comments and be interactive, not interrupt, just interactive. But I'm going to ask Sergio to start, just, I think, for the general audience and giving us a small overview of the importance of the calf pump in terms of edema and venous return. And we almost, measure it like cardiac function now. And yeah, if you can just kick off.
Sure. And I think, well, first of all, thank you so much for having me here. It's lovely to be together. Let's hope soon in person. And it's a very easy task, actually, the one you have given me, Laura, because it's like talking about the importance of the heart. Because indeed, the calf pump is usually called by experts as the peripheral heart. And it really goes with the human nature evolution, I would say, for which we evolved from quadrupeds to bipeds. So we usually don't see varicose veins on our arms, but in our legs. And the way we can counteract this Darwinian price we have been paying for our evolution is thanks to the calf that is indeed pumping the venous blood back against the gravity force. And this really goes with the indications we give every single day to our patients of keeping themselves in movement, particularly after a sedentary time like the one of COVID, but always looking for evidence-based data, always looking for a multidisciplinary approach. So I really congratulate the initiative for bringing together experts from the different fields, including orthopaedics, podiatry, because, also the weight bearing has to do with the function of this pump. There is a nice paper by Louw that is showing how you can increase by 4 times the risk of developing venous insufficiency if you don't put down the weight in the right way. So I think we are touching a very important heart topic today.
Thanks, Sergio. Yeah, and I think what I wanted to also really get from Fred and Sean and Nicole is how we can improve the calf function in people who aren't using it. Because we, from a vascular perspective, especially venous, we'll see a lot of patients with severe edema or non-healing wound. And even with compression, it's seeming the most effect it has is really the ejection fraction of the calf pump. So Fred, do you want to start with anything you can surgically do? And usually it's from patients with, we would say flat feet or foot issues where they're not using the gastric or soleus muscle.
Thank you, Laura. I mean, we find this being a foot and ankle subspecialist, this is one of our biggest problems or challenges that we faced with on a day-to-day basis, specifically related to post-op swelling, calf insufficiency, wound swelling, wound leakage, bleeding, and then the elephant in the room is infection. From my point of view, it's the thing that frightens me the most. If we're going into a foot or a very tight gastroc or an insufficient calf, which is leading to venous pooling or certain troubles like that, I personally like to have the vascular or the venous surgeon to have a look and see if they can optimize patients in a more elective fashion, but from a surgical fashion, we've got to try to keep that down as much as possible. We use several tricks and modifications of what we've done, which can start from wound closure, where we're doing several layers of wound closure, meticulous coagulation, and looking at trying to not get too much bleeding into our wounds first and foremost. But if we're not getting the fluid or the swelling to leave, we're going to have a problem long term, specifically in the first week to 2 weeks. Elevating the feet helps greatly. I try to get patients to move their toes. Intrinsic exercises, which are started day one post-operatively, to help even starting with the foot to move it. And if you can potentially move your calf, if you haven't touched that calf too much with surgery, then start moving your calf and contracting it earlier. To us, makes a great difference. Earlier mobilization and getting up sometimes is a bit tricky if you've had your one leg operated on, but certainly getting up earlier, moving quicker, and all the rest helps. Other problems, if there is a chance that we can optimize our hosts, I'd find it from a foot and ankle point of view, it makes a huge difference. If we've got a patient with who's very obese, who's got lots of intra-abdominal pressure or anything like that, which is causing our problems, I think finding the specific cause for what our venous insufficiency is before and trying to sort that out makes a great difference. But from an intraoperative point or post-operative point of view, getting them to move their foot, to move their calf and everything as quick as possible makes a huge difference, albeit sometimes on a static fashion where you're not moving the foot, not moving the leg itself, you're actually just moving the calf by contracting it inside a cast or a boot. Just makes a huge difference.
And Fred, but on that note, if a patient's actually not using their calf pump from a foot or ankle issue, so they can't, fire it off and eject that amount of blood into the venous system, is there any surgical procedures you do or could do that would improve that foot structure to enhance the use of the gastroc or soleus?
That's a very good question. If I've got a fixed gastrocnemius contracture or fixed gastroc soleus contracture, you can consider releasing it, but releasing would certainly weaken the exact pull-off of it. So that's a bit tricky. But moving on other muscles on the inside, if I've got a flat foot or something and someone's not moving their calf as much, then potentially addressing the flat foot issue, which allows them to address their step off, which usually allows them to address their calf issue as well. Plus minus doing some lengthening of tendons could certainly help strengthen, or hopefully help strengthen that. The irony is that as soon as you lengthen that tight Achilles tendon, you weaken it. But that doesn't weaken the calf pump mechanism, that just weakens the line of pull. So you lengthen the tendon a little bit, which weakens the line of pull of the tendon, but not so much the calf pump. The calf pump itself is still working, compressing those venules and getting them and getting the blood up the leg.
And I think actually, Sergio, in your country, I visited the deep valve unit in Modena, and they give a lot of teaching on venous edema. But anyone who's not using their calf pump adequately, they're sent for physio. So Nikki, from a physio perspective, what if a patient comes to you with that? Because I often send to physio here, not to you because you're on the other side of the country. What would you advise them to do to try and enhance that calf pump?
Well, if I can actually just touch on the previous discussion, I think pre-operative physio we found to be incredibly beneficial, where we've actually already trained the patient in what type of exercises they're going to need to be doing after they've had the op. Because to try and get them to move something directly post-op, they're quite nervous. So a couple of days pre-operatively to just explain to them the calf pump, the foot pumps that they will be doing, how to contract your gastroc or your soleus without movement. It really is beneficial post-operatively, we found. Then, of course, a lot of it is manual therapy. We can actively get the patient to move the foot, actively contract the gastrocs, or we can passively do it also, just with gentle stretching and dorsiplantar flexion, again, depending on the mobility or the range of movement of the ankle. If we really are battling, electrotherapy stimulation does help too, where we can place external electrodes over the muscle itself and cause electric current to actually get a muscle contraction. Of course, this has to be in a patient that doesn't have any motor or lower motor neuron injuries, because the stimulation required will be too high, then you'll have a few burn wounds. But yeah, patients sent to me is a lot of gait retraining, looking at, the heel strike, the toe off, general strengthening, using elastic bands, using compression stockings, a lot of treadmill walking where we can increase and decrease the incline as required in order to try and increase the strength and the use of the muscle correctly.
Okay, thanks. And Sean, I think we've had so many of these from our Lympho-Life group, and I think also people, like I see more and more patients with edema, but they don't always get sent to podiatry or physio or anyone just for edema. But I know that I've sent to you here for many. So what do you try and optimize in them more?
Well, I think the big thing when you're talking about gait and function and the use of the calf muscle pump is you want efficient movement in the sagittal plane. And so many things can influence movement in the sagittal plane. So where Fred was talking about tight gastrosoleus complex restricting ankle dorsiflexion, you get tight FHL, FDL muscles restricting movement there. There's a lot of work that was done early on by Howard Dannenberg in designing orthotics that actually unlock the function of the hallux. It's called functional hallux limitus, where just in function, the hallux gets blocked. And it's not a true hallux rigidus, which is another complex all on its own, but you want to get the foot functioning efficiently over the two pivots, which is the ankle and the metatarsal joints. And if you don't get that functioning, you're going to find the patient will slowly and surely begin to shorten their stride length and walk without contraction of the calf muscle. So when I start looking at people, it's why is it happening? Why are they not functioning that way? Why are they not contracting their calf when they walk? And in the majority of cases, it's the fact that they have got some blockage in the sagittal plane movement. And we need to try and understand what's causing it and how can we control it with an orthotic and or footwear. And there's lots of new running shoes in the market with fantastic rocker bottom soles. The best thing ever in controlling sagittal plane function. You just put somebody into one of these shoes and automatically they're better. So they can start extending their stride length, which is then going to what Nikki's saying, we're talking about gait re-education. So it becomes a sum of all parts and a sum of all disciplines where you want everybody to bring their game to work on the patient's ability to walk with a slightly longer stride length. And as they're swinging the advancing limb forward, they're going to contract the calf of the ground-based limb. Just recently, I've read some work done by another podiatrist in South Africa, Ned Thompson, who did a PhD on the foot pump. So we actually need to start going back a little bit and look at the foot pump, which precedes the calf pump. And it's this whole synchronization of cardiac function, blood returning to the heart, as well as gait. It's a multi-system thing, and it's the more I've looked at it, the more complex it's got. But the simpler it is at the same time. If you just identify where the problem is, you know what to do to go forward to correct it and to ease up the patient's problems.
Thanks. I think you're right. Yeah, the foot pump does have a role. It's less of a muscular role, but it's definitely part of the whole system. I think there are 2 points I want to pick up. Fred, you mentioned about obese patients, and that's a significant issue with patients with peripheral edema. But I think those 2 things, the obesity and poor use of calf pump, which is often gait or foot issues, are big problems for managing patients with edema. And we will use compression stockings, which patients hate. But again, Sergio, I think you could comment here, we're gaining more understanding on compression, but it seemingly has its most effect in the deep compartment and actually around gastroc to increase ejection flow.
Yeah, sure, Laura, and congratulations for what has been brought up so far, because some important topics I've raised already, I would say. Like foot pump, up to my knowledge, according to the literature, is about 20% of the venous return that we have. The 60% more or less is coming from the calf, and another 20%, let's say, so from the thigh. This is really influencing the way we are suggesting our patients to behave. And of course, the opportunity of activating the foot pump, for example, by walking, and it's great to have orthopedics and physiotherapy experts today with us, could influence the result, meaning that it could be helpful for the venous return because you are squeezing, of course, the foot pump, but at the same time, it could be a problem from the joints perspective. And that's why we usually manage these patients with a lot of standardized exercises in the aquatic environment. That is the best form of compression we can get, because every single centimeter of water into the pool is 0.7 millimeter mercury, which means that when we are standing up simply into the pool, at the bottom, if we are like 120 centimeter, we have 80 and more millimeter mercury. The stockings we are usually talking about are in between 20, 40, let's say. So we really focus on a combination of physical exercises into the aquatic environment, combined, of course, with compression when they are outside the aquatic environment. And it's really interesting what was mentioned before about the ankle range of motion, that we found to be directly correlated to the aquatic exercises we were proposing. Now, the important thing, and I like to ask the other guest of today, is to make sure we protect our patients from not evidence-based data, not certified products. For example, if we are talking about, it was mentioned before, the different shoes we can find in the shop proposing a benefit, I think we should make sure that the claims of these commercials are in line with what these products are really doing, meaning that specific products are certified and others are not. So it's always fundamental to go to the specialist, I would say, to ask for recommendation rather than just following the commercial. The same thing for the compression stockings, because, for example, in Italy, we have many that are not certified and that are also uncomfortable because they're not properly prescribed. While if properly prescribed, we know that the compliance, so the acceptance of the patients is high. The same for the aquatic environment, where you have centers that are proposing whatever kind of exercise without proper scientific validation, while we should rely on evidence-based data. So I think it would be interesting to know from the other experts, at least for me, if also your ward, in terms of specialty, is affected by misinformation and not certified products and not certified claims, because that is exactly what we have been working on heavily in the last 2 years in a project that we will present at the Expo in Dubai next February. Are you affected also in your field from this, let's say, fake news?
Very much so. You know, the inner cell and orthotic industry worldwide is worth billions and billions. And if you just Google orthotics, you'll find anybody and their pet dog is designing and selling orthotics. And orthotics, you know, even after we've been making them for so many years, we still probably don't understand fully how they work. So people will supply all kinds of OTC orthotics. You can go to, you know, supermarkets and pharmacies and buy things for 50 Rand. And then people say, but I've had orthotics, they didn't work. So where did you get them? So I bought them, you know, online from someone. And that definitely affects it. So orthotics are specifically designed and are designed per foot, not even per pair. You know, each foot can have a completely different design. So there's definitely an influence in the media. The shoes I was talking about are the athletic shoes with the rocker bottom soles, which have actually changed the record book. That's a whole nother discussion. But they do have been, and there's a lot of literature that's been done on it, on showing how it improves stride length. So I was speaking about stride length being involved in the ability of the calf muscle to contract. So the shoes I'm talking about, there's been a lot of literature on that showing that it actually does exactly that. It increases and improves plantar flexion and improves stride length, which is why the shoes have been breaking all sorts of records. So that's a whole different thing. But there's definitely a lot of fake product, poor product, poorly designed product, poorly made product out there. And then by the time the patient comes through to see you and you say, you need orthotics, they say, no, thanks, I've already had 5 pairs that didn't work. So it is a challenge.
I think it's interesting. I was attending a talk about a year ago by one of the head foot and ankle surgeon for the NFL, and he reviewed all. Just to give an idea of it, he reviewed all of the major brands football cleats that were worn in the NHL. A lot of them very well-known brands, which were charging very large dollar amounts for their shoes. And the interesting part is less than 60% actually passed muster for being for the 3 or 4 things which they required, despite incredible advertising budgets, incredible product placement by athletes. Very few people had actually done academic studies and looked at which shoes are being produced by major industry to see what's happened, and he'd found that over 60% hadn't passed the muster. You know, where simple things as providing basic support to the foot and ankle wasn't there. You know, they looked great, but they wouldn't work. And I think that's our fight, is using evidence-based medicine to get people to use the correct things going forward. Because if we don't, we're going to lose the hearts and minds on people actually using proper devices and proper accessories without them even knowing it.
You know, this is interesting. Sorry to jump in, but you just said a number that is 60%, and we actually running this campaign following a paper from Poland that reported 40% indeed, so 60 and 40, same number, because you said like 60% were passing the test. Like 40% of the medical websites were not passing the test for misinformation, and they were actually shared in average 450,000 times. So what Laura is putting on today as a show, I think, is very important because it's a showcase of evidence-based needs rather than just whatever opinion out there in the market.
What are you seeing it in a lot of, Sergio, in terms of products?
So much that we decided to run a full campaign globally and bring that to the expo. So we see them a lot in terms of compression. One major issue in Italy is, for example, they all know the dinars. I don't know if you use them in South Africa, but the dinars is a unit of measure of how much the product weighs, basically, not how much pressure you have. And all the people are looking for these stockings that are not really expressing how many millimeter mercury they are creating. Or they are just going to the pool, doing strange exercises, maybe also having very cold and very hot experiences, while in reality, all you need is the physics, for example, in the aquatic environment, of course, the proper temperature, but of the pressure that is coming also from the density of the water, for which thermal environments have a particular interest for the patients, also because of the solutes they have inside that could have an anti-inflammatory effect.
No, thanks. I think the compression industry is huge, yeah, and it's sort of exponentially.
But Laura, in reality, I don't know how much in South Africa, but here we have venous active drugs, and we have also topicals that are used a lot. And there are like a lot of products that are not validated and that they think they might help, and they get all these pills, but they are surely not the ones in the literature we have.
That's true. And yeah, you're doing a great thing by actually exposing that, the fake news. So you're just running a whole campaign. I think as well, Fred, what you see with the sports, I think a lot of it must be in sports, probably sports and aesthetics as well. And there's compression being used more and more in sports. I don't know if your patients ask you a lot about that. You probably see a lot of athletes.
I talk to my patients a lot about that and always ask what sport or what physical activities they are doing. And again, I'm really happy to have today colleagues from other specialties. We created a group called Phleb-Ortho that is bringing together orthopedics and phlebology, because we used to say sport is like the best drug ever. It is acting on all the different systems of the body, if you think about that when you're talking about movement. Like a drug, it can be harmful or beneficial based on how you administer that. So if you think about the word agonist, inside you have agony as the word. So sport practice in a not appropriate way becomes an agony, and that's why we have experts like the one of today making sure that we don't injure ourselves when we are doing sport practice. So yes, we do use a lot of sport as a therapy and as a prevention, but cautious that it can be also harmful.
Interesting that Fred was talking about the cleats, or boots in NFL football, because if you look at the construction of that kind of shoe, it hasn't changed dramatically for a long time. So they're pretty much the same things they've always been. Like I say, they've changed the uppers and they've done all sorts of things. But if you look at a lot of the boots now, they're essentially a sock with a plate with studs on it. That's really all they are. There's like absolutely no support in the shoe. There's an Australian podiatrist by the name of Simon Barthold who's done a lot of work redesigning sport-specific shoes. And he started with Australian rules football, and he's done hockey, he's done netball. So they're starting to look at it. But the majority of the research budget that goes into athletic footwear goes into running shoes. You just need to see the Nike research lab in Oregon, which has got a 200-meter force plate track with billions. So the majority of the money goes there. And other sports just get the same things that they've always had, just tarted up with different colors. So I would agree with that comment that 60% of the shoes wouldn't pass muster. They may look fantastic, but they're not fantastic. So it's just, as long as the shoe looks good and it sticks to the turf and they don't slip, that's a good shoe. There's not more to it than that.
Okay, I think you're right. And it's, a lot of it is in sports, though, sports and aesthetics. I think just one other aspect of the calf pump, going back to our topic, I wanted to bring up, because you're talking about peri-operative patients, and Fred, you were saying about optimizing them beforehand, is I make a lot of use of the lymphedema therapist as well. Because once, they've got edema in that leg, if it's from venous or any origin, there's some secondary lymphedema. So they are very good pre and post-op therapy to use. I don't know if you make use of them at all.
I certainly do. I mean, I usually refer most of my patients to you, actually, Laura. I'm looking at that and getting my worry or my gist is certainly if there's any pre-op swelling or peripheral venous edema or anything that I can sort out before I operate, if I plan my operation, it has a huge post-operative influence and effect on my surgery, specifically on wound healing, on rehabilitation, on return, even with bony work, which takes 4 to 6 weeks to heal. And once the swelling comes down, most of the pain seems to settle as well. My first 2 weeks are probably the most important from a swelling point of view, because I've, with surgery, initiated a swelling process, and then I've got the background of venous swelling and edema around there. So if I can in any manner optimize someone to pre-op and post-operatively get on top of that, I'm out of the worst neck of the woods at around 2 weeks when it comes to infection, wound breakdown, and complications like that, which to me are one of the big markers of where things can go wrong in surgery. So the lymphedema and venous treatment specialists to me are paramount.
And I think sort of brings me to another contentious point, and we've had these discussions. Nikki, you had an interesting point of treating them pre-op as well, because we'd normally give compression and then manage most of it post-operatively. So that's the idea. You're going to treat the patient pre-op. They could learn physio, they could get orthotics, they can go for manual lymph drainage. But that whole thing in our environment then becomes an issue for the patient with time and cost. So it's very much an ideal world. Again, so finding that balance is hard. Any other comments about the vein heart or pumping?
The point that was made earlier about people going to exercise and exercising poorly. And that's something that I see a lot in my primary practice is sports medicine, is that people will go and join a gym or join a boot camp or do something for exercise, and they will exercise poorly. And when you're wanting to rehabilitate somebody, you do need specific guidance of people who really know what they're doing and how to instruct them on the actual correct pathways of movement. Because, you'll watch people doing bicep curls in the gym and they're flinging the weight around thinking they're fantastic, but they're actually not doing the work. And it would be exactly the same with contracting the calf. If somebody's got an incompetent medial column and they're trying to do calf raises, they're probably not really doing the job properly. Posterior tibial dysfunction, something Fred sees when it's disastrous and it's gone really bad, and that's not little surgery to fix that. If post-tib is not firing properly, the calf can't fire properly. It's literally an impossibility. Physically, it cannot happen. So sometimes we have to pull people out of exercise that they're happy doing and say, let's send you into a physio or a biokineticist and teach you how to do the exercise properly, get the movement pattern correct. and then the rehabilitation will be a lot easier. So that's, something that I see is that we have to sometimes get people to crawl again before they can walk, before they can run.
So like a calf rehabilitation team.
Yeah, completely.
But working on that is actually education of everyone in those gym settings. Unfortunately, you've got your personal trainers and that's where we sit as physios with a problem. Personal training session costs 50 Rand, your physio appointments 400. And they're not wanting to do that referral purely because they haven't been educated. And that's something that I'm working quite closely with local gyms in the area, is recognizing of an issue and trying to get it referred to be seen a lot earlier. But it all comes down to education and, again, actually acceptance of what we're trying to get out there.
I think it's fundamental what you have put on today, Laura, of different specialties I mentioned multiple times, because we are used to say venous and lymphatic disease, and then in general edema, is like flipping a coin. Whatever kind of health professional you are, you have 1 out of 2 chance of having to deal with a patient who has some issue with the venous and lymphatic disorder. And in reality, whoever is managing joints and muscles is actually managing the pumps that are making the edema and the venous and lymphatic disorder managed at best. And this should be particularly presented to the public after the difficulty of the pandemic. That is an opportunity to remember that in reality, a significant part of the population is in permanent lockdown, meaning that rurality is a very common condition for the public. So the management of edema at home and teaching how to manage edema by proper exercise, proper physical activity, even at home, is something that will remain after the difficulty of the pandemic. Just because, again, the lockdown hopefully will be over soon, but the rurality will remain. So teaching the patients and the public how to manage at best a condition that is present in 1 out of 2 is fundamental and requires multi-specialty approach like today.
Yeah, you're completely right. Yeah. Fred, we need a clever ortho group as well here.
Well, you can start one whenever you want. You know you are part of the team. No, but
Okay.
in Dubai, we will have a session dedicated to this. And indeed, whoever wants to join in February, we are really looking forward for the collaboration with orthopedics and rehab. We have always been working a lot about that. I don't know how right we are. We do some sort of Fukuda modified test in the office to see if the patient has some sort of weight-bearing issue. Because all the patients who are coming in our office then go to the experts of posture and rehab to make sure that if we are fixing a pipe into the wall of the house stand up still rather than bending.
No, true, thanks. And I think, the other thing about patient education is also educating each other. And Sean was part of a group we had called Limb for Life, and it was multidisciplinary again, but just in an educational group, because we often have gone so far into each of our own specialties that we don't know what everyone's doing or what's updated where, what happens to the patient. So it's probably education of us and the patients. Yeah. Okay, I think I must start rounding up. Are there any further comments anyone wants to say before I close off?
No, I was just mentioning if this goes out to the public, to always rely on the scientific societies and the expert, for which we, for example, created a web page where the patients and the experts can write and report eventually encountered misinformation. So to always rely on the experts and in this case to your scientific group in South Africa, rather than just surfing dangerously on the web.
Yeah, thank you. So no Dr. Google. And I think, a few key elements is that we actually should be managing patients with edema pre and post-operatively. We definitely need a multidisciplinary approach, and we need to further educate our patients. So thank you for joining.
Thank you so much and congratulations.
Okay.
Ciao.
Bye. Bye.